Welcome everybody to this third and final seminar, which is a collaboration between the Council of Deans and Health Education England, NHSE, has now become. This has been a fabulous opportunity to look at advanced practice and look at what is going on in the landscape. And it gives me great pleasure in this final seminar to introduce a panel of speakers who are going to rapidly present 4 key areas which have emerged from our discussions over the last year. And also we got to have an opportunity at the end of the seminar to debate how the Council of Deans and this community would like to take the whole issues around advanced practice forward and ensure that this group continues if we think appropriate. So without further ado, I'm going to introduce you to our wonderful panel who have agreed to speak this morning. And I hope during their short presentations, you will think of questions. There are 2 ways in which you can participate. And one is you can enter questions into the Q&A, and then we will ask them, or you can make comments in the comments. But without further ado, I'll move to introduce our panels. First of all, it gives me great pleasure to introduce Professor Melanie Rogers, who I worked with a very long time ago in advanced practice at the University of Huddersfield. And it's a real pleasure to see you again, Melanie, who is going to give us an overview of the ICN Nurse Practitioner Advanced Practice Network and the horizon for advanced practice internationally. She will be followed by Louise Beasley, a good colleague of mine, who's going to talk about, from her experience, interprofessional education in delivering advanced practice programs, and probably raise the question on whether advanced practice is a forum in which we're seeing a pedagogy of interprofessional education emerging. The third speaker will be Vicky MacArthur, who's going to talk about how sharing good practice on advanced practitioners around the endpoint assessment, which is part of the degree apprenticeship in the advanced practice. And last but not least is James Pratt, who's going to give us an overview of employers' perspectives on the supervision process. So I will first of all move to Melanie Rogers, who will give her presentation.
Thank you, Annie, an absolute pleasure to be here. Felix, could you put the slide up, please? Thank you. So it's just a couple of slides. That's the one. Thank you very much. So greetings from sunny Huddersfield, but also from the ICN Nurse Practitioner Advanced Practice Nurse Network that I've been involved with for probably the last 20 years. I was previously the chair, and I'm now the director of the Global Academy for Advanced Practice Research and Enterprise. As we know, over 400 million people lack access to health services, and all of us want better health and better outcomes for our patients. But there are significant issues in terms of our workforce. And globally, the main advanced practice discipline is nursing. So excuse me for talking about nursing, because I know that in the UK, we're obviously looking at a multi-professional framework, but internationally, it's mainly advanced practice nurses that the ICN are working with. And we know that they make a significant impact in terms of universal healthcare and the sustainable development goals. And I'm still working as an advanced nurse practitioner in primary care. And I love the fact that we provide holistic care. We see our patients all the way through their journey, and we're highly skilled professionals. But internationally, there are still significant challenges. Many countries still lack role clarity, legislation, regulation, education, training, and funding. At the moment, internationally, there's 87 countries that have the advanced practice nurse role, which is either nurse practitioner or clinical nurse specialist. And the development of advanced practice since I've been involved with the international community has been exponential. Many countries are looking at what they can do to develop their workforces and see advanced practice as a way forward. And many countries are looking to us at our approach to the multi-professional framework and how we are integrating advanced practice across the disciplines. I worked for many years with the ICN to develop the guidelines for advanced practice nursing, and significantly it took 2 years because we had over 130 countries that needed to buy in, and it was very difficult to get some sort of global consensus. If you haven't seen the guidelines, do have a look. They focus particularly on the umbrella term of advanced practice nursing and recognise that countries will be developing the role depending on the context of the country and the specific needs. So the two most significant roles that are seen internationally are nurse practitioner and clinical nurse specialist. There are other roles like nurse anaesthetists that are also developing, and many countries have moved significantly forward in roles of advanced practice. And I've been lucky enough to work with countries like Hungary that have a very medically orientated approach to medicine or to healthcare, and they've even managed to get up their first advanced practice nursing courses. So even when they are faced with many of the challenges that we had in the UK 30 years ago, countries are moving forward to develop advanced practice. Most countries, unlike the UK, regulate before they even start to educate. So we are in the significant minority. There are only 2 countries that haven't regulated the role, and we continue to work with countries to help to support the development of their education, to support regulation and policy. And we're at the moment undertaking a big piece of work in Africa to develop advanced practice nursing, and one of my colleagues has just written in the INR about that if you'd like to know. The ICN NP APN network's been going for about 25 years. We're 3 to join, and it's open to non-nurses as well, policymakers, researchers, and there is lots of activity in terms of practice, regulation, education, research, and the Global Academy for Research and Enterprise is working at the moment on the first systematic review of systematic reviews for advanced practice, which will enable us to have a strategic direction for where we need to be putting our energies in terms of research internationally. And I'll leave it at that for now, because I think I just hit 5 minutes.
Wonderful. Thank you very much, Melanie. I'll move to Louise Beasley.
Good morning, everybody, and thank you again for being asked to undertake this session on interprofessional education. So if you go to the next slide, please, Felix. So we all know that interprofessional education is really important in advanced clinical practice, and for many years, even prior to the multi-professional framework in 2017, the advancing practice curricula within HEIs was starting to develop a real culture of multi-professional input, largely founded in School of Nursing and Midwifery arenas, but absolutely and encouragingly benefiting from the rich learning culture of multi-professional education. Next slide, please. So what do we mean by then when we talk about interprofessional education? So this is a quote that goes back to 2002 from the Centre for the Advancement of Interprofessional Education. So IPE is an occasion where 2 or more professionals learn with, from and about each other to improve collaboration and the quality of care. And CAPE have been very much central to this development. If you can just click on Felix. That's lovely. And next slide, please. So if you've not taken an opportunity to look at some strategies on interprofessional education, please do have a look at the Centre for Advancement of Interprofessional Education resources, and they apply very applicably to advanced clinical practice. Next slide, please. We know the benefits of IPE are massive. It's well cited in the literature, improvement of job satisfaction, enhanced sense of professional identity formation and team working, increasing in mutual respect, and so forth. The list goes on. However, up until this point, interprofessional education has very much been grounded in pre-registration practice, and a lot of the information that you'll see from CAPE and from other resources actually focus very much on pre-registration. Next slide, please. So can you just put all these on, Felix? That's lovely. Perfect. Backwards. Lovely. So just thinking about then how we develop and implement an IPE strategy in advanced practice. So it's thinking beyond pre-registration. It's thinking about how we incorporate it beyond CPD delivery as well, where there's been a culture of developing advanced interprofessional education, and thinking about really boundary spanning in terms of our vision for interprofessional education advanced practice going forward. When we look at what we do in the classroom, which to me is a great art in many ways, where we interpret as academics the standing knowledge of the multi-professional group in front of us, and also the varying exposures and experience of that multi-professional group, I think we can probably call this IPE with a twist. All participants in that room are striving towards a different profession, a new identity in terms of their professional status, but they're also drawing on those foundation experiences that they've had, which underpin their original level of registration. Are we then talking about multi-professional education? Well, this is defined in the literature as occasions where two or more professionals learn side by side. But it's more than that. It really is that blended hybrid approach of having experiences which underpin us as foundation registrants of our profession, and also an acquisition of new knowledge as we all strive towards this new identity as advanced clinical practitioners. So a hybrid approach, maybe we're looking here at a new pedagogical approach as well. Next slide, please, Felix. Oops. Sorry. So this is just sort of an overview of some of the ideas that have really sort of influenced me as an academic within this arena. So thinking about how we develop interprofessionally, how we develop in that multi-professional culture, and how we evolve to perhaps an advanced practice education culture where we truly cross professional boundaries. We have a community of academic practice which spans across multi-professional groups, and that is growing now within our HEIs. That essential element of co-curriculum production across having that multi-professional input into curriculum co-production, and also our cross-partnership input as well. So we really truly get that blend of theory, clinical, and also multi-professional expertise in curriculum development. We need to go back to our pre-registration preparation and really understand the basis of that as well. And we know that pre-registration curricula is changing rapidly. For instance, within nursing, we have the future nursing, and within pharmacy, we have the future forward pathway for them too. So very much now having to realign ourselves with the progression of the pre-registration curriculum too. Initial needs analysis are critical, and this is something that's been reinforced by the degree apprenticeship structure that we've had within the school, and which I've seen sort of help to really identify where practitioners are coming from in terms of their original pre-registration training, but also their experiential experiences and knowledge that they've gained as professionals in their own right. We need to ensure that we're aligning assessment strategy to support multi-professional practice, and also encourage that really rich culture of peer-to-peer learning. And we know that this happens not just in the classroom, but in the coffee shops and everywhere when the students engage with one another and talk about their developing practice. We need to learn, think about our supervision and assessment. We know that it is a multi-professional supervision and assessment team that we're engaging with in practice, and it's thinking about how we link knowledge and exposures to ensure that we're meeting the requirements of the knowledge of advancing practice across the professional groups. And then, of course, there's the link with the pedagogy of work-based learning. Really important. These courses that we deliver are actively engaged with work-based learning and work-based assessment and supervision. And when we develop our strategies going further, these need to be central to some of the concepts. So this is kind of a mind map of where I think we need to go as academics, where we've come to in terms of our knowledge. And as Annie said, maybe we are looking at a new pedagogical approach in terms of how we incorporate interprofessional education and multi-professional education to ensure that everybody has the appropriate preparation for their advanced clinical practice career. Thank you.
Thanks, Louise. We'll deal with questions at the end. So if we move straight to Vicky MacArthur, who's going to talk about the endpoint assessment.
Thank you, Annie, for inviting me to speak today. I'm talking about the endpoint assessment. I'm the chair of the endpoint assessment organisation for the Advanced Clinical Practice apprenticeship, which is hosted by APPE UK. So I'm here in that capacity, as well as leading the apprenticeship at Oxford Brookes University. Just a quick overview of the EPA. It's a compulsory part of the apprenticeship, and it's the assessment of the apprenticeship aspect. It's an independent synoptic assessment, so it draws together all those threads that the learners have been studying throughout the course into that one assessment. And it is set out in an assessment plan by the Institute for Apprenticeships in the apprenticeship standard for this apprenticeship, the ACP, in the endpoint assessment plan. And we have to adhere to that plan. All HCIs must follow the same assessment as set out in that. And the university in this context is the endpoint assessment organisation. The endpoint assessment itself is a 2-hour open book exam and a presentation of a practice change with a report as well. Next slide. Thank you. This is a list which is fairly extensive of the things that an EPAO must do as an EPAO. And so it's really there to show you that there are several things that we need to be able to do and adhere to as an EPAO. And so really you could encapsulate my advice for good practice in the endpoint assessment, which is to become part of a network of EPAO providers, which is what we have at APPE UK. So next slide, please. The other thing that the endpoint assessment plan sets out, importantly, is that every endpoint assessment organisation, so in this case, every HEI, should collaborate with at least one other EPAO delivering the advanced clinical practice EPA. And this is to ensure consistency across assessors and across assessments. And that is an essential part of the good practice of running the endpoint assessment. They should also participate with an endpoint assessment organisation network to share and discuss areas of improvement and to report on best practice. And really that's what we do in the endpoint assessment organisation network that APPE UK hosts. And I can see many of the members of that network are already on the call today. And that collaborative working has meant that we have produced a range of resources for the members of that network. And if you needed somewhere to start with those resources, which are all available on APPE UK's website, we've produced an addendum to the endpoint assessment plan, which shows you all the clarifications and all the agreements that we've made as a network about how to support and deliver that endpoint assessment. And you can see them set out in that addendum, which is on the website. And every meeting, we have an HCI that presents their experience of running the endpoint assessment in their own organisation. And that helps to raise questions and it stimulates discussion, and it ultimately means that we are sharing good practice and promoting consistency. So the next slide, please. So you can see that this is a map showing the members of the Endpoint Assessment Network. We have approximately 50 universities who are members of that network, which is almost every university in England. And if there's anybody here from a university that isn't a member, we'd be very happy to welcome you as a member to that. And these are the range of resources that you'll find on our website. The addendum, which I've already mentioned. We've produced a question bank of 24 questions from which to draw from for the open book exam. We've provided example exam questions to use with your learners to prepare for the exam and case studies. And we also have just set up an independent assessor subgroup. So if you're an independent assessor for the EPA, that's where you can get support and share good practice and also promote consistency across that. So that's just a really whistle-stop tour of the endpoint assessment and what might be good practice. Thank you.
Thank you, Vicky. And our last panel member who's going to present is James Pratt, who's the Trust Lead at Nottingham University Hospitals. James, the floor's yours.
Thank you, Annie. You can remove the slide from the screen, so I haven't got any slides, but I have got one which I mentioned. At least I can see my face. So my name's James. I'm the Trust Lead for Advanced Practice at Nottingham University within NHS Trust. Thank you for inviting me. I feel a bit of an imposter being the only employer on the panel, but what I'm hoping to do here is just to give you a bit of an overview of how supervision is operationalised from the perspective of an employer, some of the challenges and bits that we face when we do that. So I think the first sort of big take-home point, you can take anything home from what I say, is that supervision from the perspective of advanced practice cannot be seen as an addition. So it's not something that comes as an extra to the trained advanced practitioners or to qualified advanced practitioners. It's a fundamental part of the role. So it's absolutely fundamental and needs to be part of the training and part of our qualified advanced practitioner career pathways.
James, we're having a little bit of problem with your microphone.
Okay,
I don't know.
quite checked it at the start.
Yeah.
We just try change.
Is that working better? Can you hear me now?
Yes, that's brilliant.
Is that better? All right. Sorry, I'll go back then. So the main point I wanted to say, which you'll have to emphasize again then, is that supervision can't be seen as an addition to advanced practice training posts or to a qualified advanced practitioner teams. It has to be seen as fundamental part of the role. And because of that, it really has to be seen as an absolute priority in the planning of advanced practice. So why is supervision really, really important for advanced practitioners? Well, I think you can look at it from a few different lenses. You can look at it from the lens of the employer, from the employee, and from the whoever's delivering the education from a higher education institute. So first of all, if you think about from the perspective of an advanced practitioner or a trainee advanced practitioner, many of them are moving from what would be a base profession role, which is regulated at their base profession, moving into an expansion of practice. And as trainee advanced practitioners and qualified advanced practitioners, they go through periods of feeling like imposters. They feel like they're going through feelings of disconnection. They have a lack of familiarity sometimes in the situation and the role which they're in as they take on new skills and new ways of working. They also are taking on a new career pathway, and for able to progress across that career pathway, we need to ensure that they're getting appropriate supervision and they're getting ongoing support and review of practice. From an employer perspective, it's really about really providing assurance to us, and that's assurance around a number of different things, because we want our advanced practitioners to work in the role of advanced practice aligned to HEE's capabilities, but we also want them to feel protected at work. We need to feel that they're able to do the level of practice which they want them to do, and we also need to ensure that our patients are protected, and that aligns with the Health and Social Care Act. When you think about point 18 on that, where it says that staff must receive appropriate support, training, professional development, supervision and appraisal for them to be able to undertake the role in which they do. So it's really, really important as an assurance pathway and a governance side of things as well, because they're working beyond base profession. So it's down to us as employers to support them. There's also the HEI, who will have their own curriculum and their own pathways and things, which we need to align to as well and make sure that our practitioners are progressing. The apprenticeship gives a really nice pathway for that, and how we can support our practitioners through their training pathways and how we align that alongside HEIs. And I sort of think of supervision being broken down into 3 different areas, which Proctor described many years ago now, 22 years ago. And that was the one around the formative function, and that's concerning the skills, knowledge, and practice the advanced practitioner may be undertaking. The restorative function about how we support them from an emotional perspective and support them through their career pathways, and the normative side of things, which is how we assure that they're meeting professional standards, they have the appropriate behaviors and things, and how we as employers can ensure that they meet those expectations and they're also developed and maintained. So when you're implementing supervision for advanced practice, there's a lot of guidance out there. So you could find guidance which is professionally related, you could find guidance which sits with HEE, you can find guidance which sits with colleges, and there's lots out there and some really good resources which can be used, but they are guidance and you do need to interpret them for your organization alongside the patient pathways which you're providing your practitioners from a professional background and also alongside the HEIs who you work with as well. And supervision planning around has to start in the early stages of the role. It's near impossible to implement supervision at a later stage for advanced practice, because what will happen is you'll plan for advanced practitioner roles, you'll think about it from a wage perspective, from a training perspective, and all of these things. But if you haven't thought, actually, they're going to need 1 hour a week of direct sit-down supervision time, how do we build that in early on? Well, that needs to be advocated in the financial models from the start. But it's not just that side of it from a funding of time, it's how much resource do you have within your organization to supply that supervision as well. So often it's not an issue with finance, it's an issue with the supervision resource. So your pathway needs to align against your supervision resource as well. And really understanding as well what the professional interpretation is of supervision. So for advanced practice, classically in the training pathway bit, it takes quite a medical model approach to it. And the reason I think that happens is because a lot of our supervisors are medics early on, but also because we're trying to provide assurance and governance to make sure that they're able to work at the level of which we want them to work. And the other thing that really needs to be thought about is how we're going to capture the supervision and AP progression. So it's all good writing all these things in, but actually what's there from an operational perspective for them to capture this supervision and things? How do we build it into portfolios? Do we need e-portfolios and things? And then the supervision planning, really, I think you break it into 3 different things. You've got that face-to-face supervision, which is that sit-down direct time where you're being supervised. It could be direct supervision, where you're working maybe clinically, but you are working in a capacity where you're directly supervised, or it could be in a more indirect fashion. That doesn't necessarily have to be clinical. That could be if you're working across any of the pillars of practice as well. The bit that gets quite confusing from an employer perspective is where does assessment sit within this? So when we blur the lines between supervision and assessment, it makes it very difficult then to do restorative supervision. But from a formative supervision perspective, assessment sits quite nicely in there. So certainly it's quite hard as an employer to separate the two, but from a governance and assurance perspective, the assessment piece is really, really important because that's what allows our advanced practitioners to work at the level which we want them to work and for us to be assured. So what do we have at NUH? So the way that we've done it here, and this is just how we've done it locally, is that we have a clear framework that supports supervision. We have a financial model which tells us exactly how much supervision advanced practitioners should need, which is beyond what's recommended from a national perspective, because we really see the value of it. But that also adds to the finances then and the difficulties of trying to get cases through and things. So those sort of having a framework, and the framework sort of gives us a few different things. It helps us the roles and responsibilities of everyone involved in supervision. It offers guidance to the ACP or the advanced practitioner during training or their transition to an experienced practitioner and beyond. It provides guidance as well for the specialties and the organization to know what should be supplied. This is written in policy in this organization, so you can't not supply supervision. It is part of the role of advanced practice. It's not an additional thing. It's not a bonus to have for them, because this is what makes them advanced practitioners. If you don't have it there, they're not going to be able to do the job and they're not going to develop their careers, and we have issues going forwards as well. And it just provides a bit of clarity as well to the supervisors. So I'm just going to share one slide, and it is just one slide, which should now be on your screen. Is it on your screen? Can someone nod? Yes, is it on? Nope. Let's try again. Let me just share that one slide again. There it is. There we are. Okay, so that should be on your screen now. Is it on your screen? Yes, good. So this is just a quick overview of how it's set up here. Now that I could go on for a whole day about all of these things. This lovely stick man at the bottom here, this stick person, is could be a qualified advanced practitioner, or it could be a trainee advanced practitioner. So all of our advanced practitioners have a buddy advanced practitioner. Okay, so the buddy advanced practitioner provides a mentorship and a supportive role to that advanced practitioner. So really doing quite a lot of the restorative supervision and some of the normative supervision, but not really doing the formative function. Every advanced practitioner has a coordinating educational supervisor with resource time. The coordinating educational supervisor goes through what is our assurance that they're able to do it. So they do the appropriate training, which we want them to do. This could be multi-professional. All right, so it could be many different professions who could do it. And then we have a number of associate workplace supervisors as well. The associate workplace supervisors could be someone in our organization who leads on clinical academic careers, who could be supporting from that perspective if the supervision at the time is needed as around, say, that pillar of practice. But it could also be the person who's working alongside that individual during their training, or also when they're a qualified advanced practitioner. What we've done is we've separated assessment out of this. So the assessment for our trainee advanced practitioners currently sits with our consultant body. They can then decide who else can sign them off against certain clinical competencies, because that's our assurance piece. And until there's any regulation or any further national regulation around this, that sits with us as an employer. So that's our assurance to allow them to know that they can work at the level which we want them to do. The other bits on there are all of our accountability pathways and things. So I'm just going to quickly unshare that screen. Which stop share there. Good. So some of the alternative ways that we've implemented. So I've mentioned the buddy system. So that buddy system is now in place across the organization. Advanced practitioners, when they go into their training pathways, are pinned to another buddy. There's a clear set of roles and responsibilities. That buddy is given time to meet with that individual. The workforce that we utilize now, as we have a large advanced practice workforce, is beyond just the medical consultants. We have a lot of advanced practitioners and senior roles who are doing it, also job plan to do it. We have supervision shifts, which are advanced practitioners who have time where they are not working within clinical numbers, where advanced practitioners can book into shift slots and work alongside them to meet their learning outcomes and their needs. We have roaming supervisors who can be booked as well. Then one thing which has been really valuable is having pillar specific groups. So we have a group of advanced practitioners who drive different pillars of practice. And if you take the education one, what they've developed is a supervision training pathway. They've developed the supervision framework. They've developed a facilitating education course, which is a 5-day course for all our advanced practitioners to go on, which helps develop and increase that supervision resource. And that also creates career pathways. You see that across all the pillars of practice. The supervision that we have goes beyond the masters. That's what's really important. Advanced practice isn't an endpoint. So there has to be further development around it. Now, it can be an endpoint that you stay within advanced practice and you stay at that level of practice, but you still need supervision. You still need to have access to assurance, and you still need to have access to different career pathways. So that's how we've operationalized it here. Loads of challenges. Biggest challenge is always money. But the big take-home message is to try and add supervision into job plans once you have advanced practitioners just depletes the workforce. So it needs to be done at the start. So your headroom in that early part has to reflect it. Bit like when you're adding CPD time and things, has to happen in the early start. So that is a quick whirlwind of how we've done supervision here. I'll stop now.
Thank you so much, James. Gosh, I think you've set the ceiling very high for people to aspire to. But I think the take-home message of you have to think supervision first, I think is really important of how you're going to operationalize it. We now have a question and answers session built in. And Felix, can I ask, are they questions not yet open, are they? So I think it would be a good opportunity for everyone to have just take a deep breath and really think about those 4 whistle-top presentations and what were the key issues for you. I have a question for all people while we're waiting for the question and answers to open. So if I could start with you, Melanie. One of the things that keeps being mooted is here in the UK, it's master's level preparation. But we know elsewhere, particularly in the US, that people are looking at doctoral preparation for advanced nurse practitioners. Where do you see the horizon?
I see the horizon as very bright, Annie, and certainly at Huddersfield, we've been looking for a long time at what we can do in terms of developing either a clinical doctorate or thinking about advanced practice doctorates. Certainly the US, the majority of training is now at DNP level. And there's a discussion within a number of colleagues in the UK about whether we think about developing some sort of route that integrates the masters so that students have the opportunity to finish their 3 years and then move on to a doctorate, or whether we think about looking at a DNP. I think there are challenges, and I'm willing to be persuaded. I'm not sure the DNP from the States is the route that we should be following in the UK, but I do think that we've got some great examples of advanced practice doctorates in a number of HEIs already, and I think we do need to be looking at that in the UK. So sorry, Jill, DNP is the doctorate of nurse practitioners that many of the US nurse practitioners are now undertaking.
I'll move to Louise. You did moot the issue about is there a pedagogy emerging? One of the things that I would say from my experience of working with the ACP cohort when we're teaching them is that you have to really value their previous expertise and then somehow move them forward to help them form this new identity. And that's quite an art form. In the new teacher coming into ACP, because a lot of the time we're using people who aren't traditional teachers or haven't always come through a traditional education role, how do you think they can develop that skill set or understand how you can appreciate what people come with and then take them forward? You're on mute.
Absolutely, Anna. Can you hear me now? Yeah, it is a real challenge, and one that we have worked with students and other academics to try and overcome in our academic sort of development. It's really important to have insight into the professional basis, the roots of professions. So I mentioned earlier about really understanding preparation of practitioners, and we all come at our education development and our insight into practice at very different sort of levels. So from that point of view, it's important. We're also looking at sort of mixed models of delivery as well. So actually, getting those practitioners in from practice to deliver cooperatively with the academics. So at the University of Birmingham, we have practitioners who are in associate clinical practice roles, who are now part of the team and actually co-deliver. And that really helps to widen the understanding and the sort of insight into the practitioners' perspectives and also their prior knowledge and experience. So it's complicated, and I think it does need unpicking. It's a really interesting environment, a really interesting professional sort of multi-professional education arena. One of the things that I'm picking up in a lot of the trails here is that people are still struggling to find identity, particularly from the non-traditional sort of medically focused advanced practice roles that we see. I see things from dietitians here, I know from speech and language therapists, occupational therapists, that identity is still forming. And as a HEIs, we need to be part of that agenda to try and support them to, develop that identity going forward. So I see it as complete collaboration, Annie. It really is important that we use our strengths from academia, but also that our partnerships in practice.
Thanks for that. Vicky, my question for you, and then I think the questions are coming in now. My question for you is really, the degree apprenticeship, the endpoint assessment was quite new to a lot of higher education institutions as a model. What value added do you think it brings?
I think it's an interesting assessment, particularly at level 7, as it's a synoptic assessment, which aren't often used yet in the UK at this level. They're a compulsory part of sort of school and secondary school type assessment, but not at university. And so it's given us this ability to think about this forming a kind of synoptic assessment of the entire course. Now, many of us do have a portfolio which is assessed, which is partly synoptic. But I think what the endpoint assessment does is it draws all 4 pillars together really explicitly. Whereas a portfolio does tend to slightly concentrate on the clinical practice pillar, although obviously you can draw other elements into it. And I think from my experience, some of the students on the endpoint assessment are able to really articulate how it's helped them to understand how they've developed as part of the apprenticeship journey, and value their newfound skills and knowledge by having to evidence that, if you like, in terms of the endpoint assessment. So I think that's been amongst the challenges, which I won't deny are there. There are some positives to be had as well.
Lovely, thanks for that. I mean, James, there have been lots of questions about supervision that have come in. And I did notice you dropped in, and this is because of my interest, clinical academics and advanced practice and supervision. And you did mention that there is a role, particularly in the research pillar. And I just wondered how that works in Nottingham. So
we have different groups, pillar groups as such, pillar specific groups we call them. They provide a number of different roles. They all have the same terms of reference, but they've been set up by advanced practitioners who have a particular interest within that pillar. But what we do is we try and align that and invite in people with expertise in it, because as much as advanced practice covers the 4 pillars of practice, it doesn't mean I have an expertise across all those pillars of practice. That would be near impossible, wouldn't it? So yes, we invite them in. So if you take something like, I don't know, if you take like the education pillar, for example, actually I would take the clinical academic pillar. So whenever we're doing any QIs, things like that, they will go through that group and they will offer support for someone, but they'll also offer support for people going through their masters. But also what's come out there is a number of advanced practitioners who have then taken on various clinical academic careers, supported by our clinical academic leads within the organization. There's also been a focus on increasing the amount of research delivery involvement from advanced practice. So there's a lot of work going on from there, and a number of different courses have come out of there. So for example, they've written a course on how to write clinical guidelines, because advanced practitioners, so then they offer supervision for groups who want to do that. That was something we never envisioned happening, but it's happened because of the investment in advanced practice over years. So it's not something that you could just put in 10 years down the line when you have lots and lots of advanced practitioners, and because you've advocated for them to have time in their job plans and ongoing supervision, they have time to support those processes, which makes my job a lot easier.
Yeah, wow, yeah. Thanks for that. So I'll move to the questions, and the first one's from Gul, and who's asking who we need to make accountable to develop supervision systems specifically for qualified ACPs specifically for qualified advanced clinical practitioners.
I would say that sits with the employer. They're employees. They are not trainees. They're not on an HEE training what was an HEE training pathway. They're not doctors. So that then I feel has to sit within the employer's perspective, and we should be accountable to supporting that. We're already accountable for doing that. The Health and Social Care Act clearly say that we should offer supervision for people to work at the level in which we want them to work. If we're not meeting that, then, well, effectively, we're not supplying the appropriate assurance for them to do. They are a very vulnerable group without regulation, and all of their practice beyond their base profession sits currently in this country with the employer. So it's up to us for employers to supply that. So I would say that sits with the employer.
Thanks. I don't know if anyone else has a view, but I think it would probably be pretty similar. There's a question about regulation, and I don't know, Julian, if you might be able to answer where we're at. I know both you and I attended a meeting recently, but Julian's got his hand up.
Yes, certainly. Thanks, Annie, and thanks all for your presentations this morning. Been really interesting to hear those. Yes, so in relation to regulation, well, previously we know that the HCPC has commissioned a research report which examined the possibility of regulating advanced practice, which didn't say no, it didn't say yes either, but said it needed to be considered further in the light of further contemporary developments. The NMC has been consulting, well, exploring, I should say, would be the correct terminology, exploring with key stakeholders the possibility of regulating advanced practice. So speaking with provider organisations, speaking with academics involved in advanced practice, and also importantly, speaking with advanced practitioner colleagues themselves about their views in relation to the possibility of regulating advanced practice. So 2 organisations have been helping the NMC do that. So that was the Nuffield Trust and also Britain Think. So that was done in a series of stakeholder meetings, engagement events, focus groups, one-to-one interviews and the such like. The NMC have received those reports from those 2 organisations and they're currently considering those findings, with those reports to be presented at a future council meeting coming up soon, and then a decision to be made as to whether or not there would be a formal consultation on the possibility of regulating advanced practice. Obviously, that would be from a nursing and midwifery perspective, because that's the purview of the Nursing and Midwifery Council. But obviously, as we've noted already earlier today, here in the UK, advanced practice is very much a multi-professional endeavour. So we need to absolutely think about that multi-professional perspective in the context of regulation, because we do have colleagues from nursing, allied health and pharmacy backgrounds who could essentially be working in the same role within a provider organisation. So definitely we need to think about that further. And obviously regulation then throws up the question of the 4 nations perspective in the UK and the differences in which advanced practice has developed across the 4 nations of the UK, and how those differences are taken account of if any steps towards regulation were to be undertaken. Recently, I was really pleased to be able to participate in a visit from senior academics from Australia. So they visited the UK under the auspices of the Australian equivalent of the Council of Deans of Health, and it's really interesting to see the work that had taken place in Australia in relation to the regulation of advanced practice, specifically for nurses and specifically for the nurse practitioner role. Really great to see that. But I think my sense of looking at that, when I was looking at the detail of it, was the extent of the control of the role that regulation conveys. And I think whilst we haven't had regulation here in the UK, it's given us a lot of flexibility to innovate and be creative in the development of advanced practice roles, which I didn't get the sense has occurred to the same extent in Australia. Partly because of the regulatory imperative that advanced practice has for those colleagues working in nurse practitioner roles. So some really interesting developments to think about in relation to advanced practice. And I think that the decision currently with the NMC is pending, looking at the exploratory discussions and then for the council to make a further decision.
Thanks for that update, Julian. I'm going to move to a question from Julie Scott, who said that clinicians coming in as guest speakers into programmes are really valuable, which I think everyone who's involved in delivery will know how valuable it is to have real world experts coming into the classroom. But they've been advised that the lecturers have to do it in their own time, and are often the universities are unable to repay them. And she's interested to hear what other universities are doing. Now, Louise, you can talk from our perspective at the University of Birmingham, but it will be interesting to hear Melanie's view and Vicky's, 3 different institutions, how they're managing that process. So go to Louise first.
Yeah, so we kind of work on a mixed model at University of Birmingham. So we have visiting lecturers who undertake sessions, and we pay them on a sessional basis. A lot of those people say they don't want payment because they're doing it as part of their clinical pillar, academic pillar, education pillar within practice, and it's good to hear that a lot of practitioners are now starting to get a dedicated time within their rota for education. So that's one model. Another model is the associate clinical professors that we have. So recently we've employed 2 0.4 whole-time equivalents, so split splitting a role really, and they are doing 2 days completely in the academic environment and still continuing to work within clinical practice as well. And these practitioners are proving to be absolutely invaluable. One of them has come with a PG cert, so he's very geared in terms of her academic development and expertise. The other one we're hoping to put through the PG cert process to really develop his academic pillar as well. The third one, of course, is the honorary role. Traditionally, honorary clinical professors or associate professors, and again we're looking to build upon our liaison with, for instance, leads within organisations, so ACP leads, as they're starting to develop their sort of governance frameworks and coming more prolific, and using their expertise in order to support across the 4 pillars of practice. So it's a bit of a mixed model, but I think one of the important things is that the education pillar is really recognised within work plans within the practice area, so that there is flexibility to support and have co-production and liaison with HEIs going forward. And that's certainly something that we're pushing at University of Birmingham, so we ensure that we've got a comprehensive and contemporaneous curriculum.
Thanks, Louise. Melanie.
So yes, so Huddersfield, very similar. We have visiting lecturer opportunities, but like Louise said, many of our lecturers come and just do that because they want to develop and they're being paid anyway. We have lecturer practitioners who work half in clinical practice and half at the university. All of our academics also work clinically to ensure that they're keeping up to date. And we have opportunities for affiliates, and we use our alumni a lot. So our alumni come back and get involved in OSCEs and other areas. And like Louise, we support our lecturer practitioners to go through the health professional education training and give them all the opportunities that we do to our full-time staff.
Yep, that's great. And Vicky.
Yeah, I mean, there's not really much to add in that. It's very, very similar at Oxford Brookes University, the same situation. We have staff who come on secondment, we have associate lecturers, and we have clinical staff with joint posts, and our current staff also, where possible, try to keep up their clinical currency as well. It can be challenging in academia, but like you said, the value of having clinicians coming to teach is something that we really see, and we get a lot of positive feedback from our students as well. So we're looking for every opportunity that we can to involve clinicians in our programme.
I'll move to James as an employer. How do you feel, if people are coming into higher education to teach, if it takes them away from practice? How do you manage that? Yeah.
It is the job. So as long as people, advanced practice is the 4 pillars. So many of the time, if they're just doing clinical practice, well, they're not doing advanced practice. It is the job, and that time's advocated for. So I'm completely comfortable with it, but there is a cost associated with utilizing that skill set from the workplace, and it shouldn't be done on kind. There is an element of, so we have similar models. We have a various amount of honorary contracts. We have people who have specific roles, part-time with us in the organization, part-time with them, all the similar things you guys said. The other thing which we do is we do subcontract a lot of it. So all clinical skills delivery, pretty much about 60% of it sits with us in the organization because we have the expertise in it. So why would you not utilize the expertise within the system which you have? So we subcontract that, which then allows me to develop those people who want to support that to do education course or the rest of it, which then helps them to develop as educators. Then the university use them to write. So because of that, what we've done with our other partner, Trent University, is we have a number of postgraduate courses which are led by us in partnership with them, but the advanced practitioners deliver them. So although they're more enhanced practice level, they deliver them. So because of those relationships, that's how it's built. But there is a cost associated with it. And I think it's important to recognize that cost from both sides, because I know how expensive it is for the university to support us. So we have various different models that have been set up over the years. But it's really important, I think, the partnership sits really tightly because the clinical expertise sits within the organizations. The academic expertise sits within the university. So how do you work in partnership to do that?
Yeah, and also how do you keep both richly insightful of the whole field of advanced practice? That's really helpful. But I mean, I think that it is a space that there is potential for abuse on both sides' goodwill, and that's why it's really good to be honest in all the relationships, isn't it? I'm very clear about it. I'm just trying to think, I'm looking through these questions and there doesn't seem to be any others other than, any others particularly. I don't know if any of the panel have anything else they'd like to add, as we have a few moments.
There's one question under answered, which was in terms of supervision, is there guidelines evidence to say whether the main supervisor should be a medic? And I don't know, there is no evidence, but there's certainly evidence saying that your supervisor should be trained as a supervisor, they should be experienced, and they should be able to supervise within whatever they're supervising. And I do, just to add to that, particularly from an advanced practice perspective and going back to the interprofessional education earlier, they do need to have an awareness of the socio-professional background, because all advanced practitioners come in at different levels with a huge amount of experience already, and their needs are different. And so the supervisor who you're offering to them may be different. We see advantages of having medics, we see advantages of having our advanced practitioners do it, or others. Our assessment piece sits with the medics majority in this organization, because that's the assurance, that's the governance. So for us, that either is them delegating it down to an advanced practitioner saying yes, they can sign them off on XYZ, or it sits with them. That's why we separated out of supervision and assessment and made them separate things.
Do you have any challenges with medics not wanting to, or not committing to the level you would expect?
So as long as they have time in their job plans, and there is an element, and this is, I think, how then the supporting frameworks which are around them. So having a strong e-portfolio with strong documentation, which makes it easier for them and lets them understand it, and a clear pathway that it works. There was definitely some pushback early on, but now it is very much a culture within this organization, advanced practices. So actually they're quite welcoming to it, really, but it all comes down to finance and time every time, and them having the drive to do it. And when the services get so large, then the advanced practitioners actually take over a lot of the restorative and normative stuff, and they focus more on the formative bits.
Right, yeah. Louise, you have your hand up.
Yeah, I mean, just to say, I mean, James works in an organisation where advanced practice is part of the culture, as he says. We know that in a lot of organisations, there are still pockets of very minimal understanding around the role. So I think the important thing, going forward is to ensure that the communication is there right from the beginning, that the want and the uptake of advanced practice is there within the teams as well. And I think sometimes it can be a little disjointed in terms of the actual concept of where the advanced practitioner sits within the team. So, I do think still there's a lot to work to be done in terms of delivering the message, delivering the benefits, and understanding the role. And I think also, as sort of an experienced academic and also somebody who also helped to supervise advanced practitioners in practice, it is about that collaborative supervision team as well. As James said earlier, he's not an expert on everything. It really is important that we try and instill this concept of students developing a supervision team so that they can really access appropriate knowledge and skill set at different stages of their 3-year journey, because it really is important that they have this rich and sort of multi-insight supervisory team. So yeah, a lot of work to be done, but a lot of work. We can see already some of the benefits of the things like the maturity matrix, where the governance and the concept of advanced practice is starting now to infiltrate into wider organisations, and also starting to see some of the benefits of the supervision assessment frameworks, on top of the work that we of HEIs have done for years and years and years, trying to chip away at that culture and trying to ensure that quality assurance around supervision assessment.
Yeah, I'll go to Melanie, and then there's a question which I'll come back to James about. Melanie.
Yeah, I was just thinking, James, it would be fantastic if you wrote up your model, because I think it is really innovative, and I think we've got a lot to learn from that. There are huge challenges we have come in leaps and bounds. But I think I qualified as a nurse practitioner 25 years ago. I'm still hearing some of the same issues from some of my students. And I think one of the challenges for HEIs is we have very little control over the supervision that the employer offers. We have our kind of mandatory advice, but I know that it is, you know, it is very varied. So I think it'd be wonderful to hear a bit more about your model. And before I forget, just a reminder, the ICN NPAPN network is holding the conference in Aberdeen in September. So do put abstracts in, do attend. It'd be great to get a really good representation from the HEIs as well as the clinicians there.
Actually, given that the supervision model, James, that you've talked about, you know, very mature, well developed, but you were there at the beginning, and some of the questions are about how do you actually start this? So how did you start? You know, what, you know.
So there's the maturity matrix, which I'm going to shamelessly plug, which is a piece of work Julian and I worked on along with others, which is a really useful starting point for organizations to see where they're at. So I think when we started, we were very lucky that we had a consultant, Frank Coffey, who is a massive advocate for advanced practice and has been for 20 years or so. So that was really helpful, but it took time to make a realization in the organization that advanced practice is more than a master's. So the master's bit for training an advanced practitioner is actually the cheapest bit. When you start to think of the time they need for direct supervision, to be off the job, all of that sort of stuff, it's incredibly expensive. So the first thing we really did was align what we wanted to be a training framework and then underpin that with a financial model. Then various other pieces of work happened, and now that's policy. So if you're planning to do an advanced practice here, so if a specialty comes to me and says, I want an advanced practitioner and I could put them on a master's on an apprenticeship. I'll say, no, you follow this model. And they'll say, well, that's 200,000 or something. So yeah, but that's how much it costs to train someone and to support them. And then going beyond that, then the time is already written in that they have their 6 hours a week non-clinical time. There's someone who will supervise them for 1 hour a month, etc. All those sort of bits. And there's various other models. So it's really advocating for it and trying to show benefit, rather than trying to save cost saving. So I think a mistake people make is they try and put roles in and try and do cost saving, but actually you have to advocate for that time, money, early on. And if you're not getting it, you're setting yourself up to fail, or the practitioners will get through because they'll work their way through. You may have someone really driven who wants to stay there and drive it, or they'll just go elsewhere.
There's various questions about will you share your model, James? So I think, and it links with Melanie's point, will you write it up and can you share it? Because I think that would be very valuable. And your slide, if you're happy for everyone to have access to that, that would be great.
Yeah, always happy. Take what you like. Pinch with pride. Don't double work.
That's a great way to be. Now, one of the questions that's coming up is in relation to the smaller professions that are now advanced practitioners and their support. James, you know, your experience of dietitians or speech and language therapists becoming ACPs, are there any special unique needs that different professional groups need?
So I think there's always something I've realized, I'm a nurse by background, it's a socio-professional background of all of the different professions needs to be considered, whether that's from the learning, their background, and the role which they will be going towards. Very much what I'm talking about here is the role of advanced clinical practitioner. You've then got alongside this lots of people who are working within profession at a level of practice as well, which is its own entity as well. And I think separating the two sometimes helps, not always. But there's definitely something about knowing what the limitations are from a legal perspective and a regulatory perspective of the roles before, and thinking about what that end role will look like, or what you can mitigate against that going forwards. So knowing around prescribing rights, radiology requesting rights, verification of death, those sort of things which make it really challenging clinically and really frustrating as a practitioner. And quite a lot of that regulation is based around profession, not actually thinking around the level of practice these people can go into, which has to be thought about, but it shouldn't be it shouldn't stop people going into those roles. But supervision should reflect that as well. So actually what we try to do with our buddy advanced practitioners, for example, they tend to buddy same profession with same profession. So that's really helpful. Not necessarily the coordinating educational supervisor, but because we want someone who's really has experience of advanced practice or maybe medic, but the buddy bit's really useful. And they've actually set up their own little networks as well, which is a little bit of a silo, but they do sort of support each other as well, going through into the same role as trainees because they have different needs.
Mm-hmm. Yeah, and for a lot of the professions, it's developing, isn't it? Because they're the limits of what their professions allow them to do is changing, just as everything else is changing so rapidly.
And just, I suppose, to add to that is to think about the language when you're doing policies and guidelines and things like that. Don't use words like doctor, nurse, use clinician, things like that. It makes the journey a lot easier and less to unpick in the future.
Really good point. Melanie.
I was just going to add in there, I think, you know, I completely agree with James, but there is also an issue in maintaining our professional identity.
Mm-hmm.
And one of my alumni students did a wonderful prof doc on nursing and the change towards advanced clinical practitioners, and how, you know, as a nurse, the participants were really keen to keep that professional identity. So I do think we need to do a bit more thinking. And certainly, we encourage our students to develop and not to sound, because a lot of them introduce themselves, I used to be a physio, or I used to be a dietitian. And I think, you know, let's celebrate our base profession and really look at this as something that we're maximizing, as well as developing as advanced clinicians.
I'll bring in Julian here.
Thank you, Annie. Thanks, Mel. Thanks, James, for noting that. Yeah, really interesting about a person's base registrant profession. I think that's absolutely fundamental to their practice as an advanced practitioner. And we must be fully cognizant that when someone starts working in an advanced practitioner role, whatever that title may be, advanced clinical practitioner or advanced nurse practitioner or advanced paramedic practitioner or such like, whatever it may be, that registrant base identity still remains, and they're practicing as a nurse working in an advanced practitioner role, or as a paramedic working in an advanced practitioner role. They're not working in a new profession. So that ability to practice in your role is entirely contingent on your base registration. But yes, people will practice in their roles differently. So a nurse practicing as an advanced practitioner is going to do that from a different style and perspective as a pharmacist working as an advanced practitioner role. But it's really key, I feel, to understand about the importance of professional identity in advanced practice to enable effective working as an advanced practitioner.
Thanks, Julian. I think it really is important, and I think as the smaller professions such as, you know, dietetics, whatever, develop in these roles, it will be really interesting to see that identity formulation coming forward. There's a question here about the research pillar in, and I know I mentioned earlier about clinical academics. I just wondered if any of our panelists have a view on the research pillar going forward and the future. A lot of consultant roles are emerging out of advanced practice, and where they see clinical academics with advanced clinical practice. I don't know if anyone's got any thoughts in there. Julian?
Sorry.
Oh.
No, sorry. Let's just repeat the question again, Annie.
Well, it's just, there's a question here from Gull. It's excellent to focus on the education pillar of AP, but an area which really needs to be looked at is the opportunity and involvement of ACPs in research. But we also are seeing advanced clinical academic roles developing, which obviously have a research and clinical component. And I've always advocated for ACPs and clinical academics. Similarly, we're seeing, we're talking about professional doctorates, which puts the R slightly more center stage, particularly towards the end of the educational process. So where do you all see ACPs and research, particularly on post-qualifying?
Yes, I think it's really important to get more advanced practitioners involved in the clinical academic agenda. The preparatory schemes that are offered by HE and NIHR do partially help address enabling progression into that research perspective. So the faculty in the Midlands has recently been supporting a couple of colleagues on the preparation programs that are offered in relation to research clinical academics. So we presented at a regional conference last week, and that was very well received by colleagues in the room in relation to what those people have been involved in. But there has been difficulties with people been able to progress into that role. So for example, like having job planning time within their roles to enable that progression from a research perspective. And it's even more difficult from a primary care perspective in trying to get that research time available and that research component being valued, particularly when there's such a pressure for seeing patients and for running clinic sessions and such like. So it's really difficult to create that culture of research being important and research being integrated for advanced practitioners. From the more education side of clinical academics, there's definitely a case for workforce development to be progressed there, and the centre is planning to do some work with the council in relation to developing the education and academic component of advanced practitioners to enable them to be involved in the education and training of advanced practitioners whilst concurrently maintaining their recency of their clinical practice. That's really important to think about. But definitely we want to see advanced practitioners as being leaders of research teams. It offers an alternative progression route to consultant level practice, for example. So I've been at conferences so often where I see our medical colleagues talking about being the principal investigator on studies, and often those studies have involved nursing colleagues or physiotherapy colleagues and such. I often sit there thinking, wouldn't it be great if one of those colleagues, one of the nurses or physiotherapists involved, was the principal investigator instead of a medical colleague, and that being enabled and being progressed and being seen as a normal component of activities. It's very much like when we're thinking about clinical practice, and I guess we often don't always have a sense of normalcy about advanced practitioners assessing, managing and seeing patients, and sometimes people might think that they need to see a medical doctor in order for something to happen, and we can draw a parallel in relation to research and the types of colleagues that should be involved from that research perspective.
Okay, thanks. I'll go to James and then Melanie.
Thank you. So I think there's a couple of bits here from an employer perspective. So there's a lot of challenges in getting qualified advanced practitioners on PhD pathways because they're already very expensive. So it's quite easy, we found in this organisation, to put nurses on pathways who are band 6 sort of level. As soon as you get into the 8B, 8C, 8 sort of D levels, it makes it more difficult. And it's also what we found from a number of them who have started those pathways, they've become disengaged with the pathway for a number of different reasons, but one, because it's taken them so far out of clinical practice, and ultimately they're here to do clinical practice because they end up with maybe 1 day a week clinically rather than what was how they wanted to see it. So what we've tended to see is we have got people on those career pathways, but what we have seen is that actually research and innovation is really, really present within our advanced practitioners, just as much as facilitating education, in that they are doing a huge amount of application of research into practice and interpretation of research into new innovation. And I don't think it's spoken about enough. There's actually the amount of application of research they do, the dissemination of it into practice, because some people don't see it as research because it's not that classic clinical academic career, but it is that piece of innovation. And then from a PI perspective, we have a number of roles we're just about to advertise to, which is going to sit within our research development, the actual research team, where they will look at taking on more roles as PIs, but also developing the research workforce, whether it's nurse or whoever, to be able to do more recruitment and things. So there's different models, I think, arising. But I think if we focus on the PhD one, there's so many challenges to get someone on board. The other challenge that I've noticed with it as well is that people who already have a PhD then say, I want to do advanced practice. And then they go, well, actually, to do that, though, because it's so vocational in so many ways, in that they actually then need to near enough leave that academic career type thing for a couple of years while they do all the clinical bits and things. It makes it the opposite challenge. So it's how you get those individuals through in a different pathway. I don't know how it will look, but I think there's opportunity there on how we can make it easier for these groups of staff.
Yeah, and in some of it is to do with pace and timing as well, isn't it? You know, and structuring careers. If one thinks of the medical training program, you know, they take time out to do their PhD and come back to their training program. And we don't always think like that in the other professions in the same way. Melanie, I think for our last point.
I'm absolutely passionate about this, and we've done a lot at Huddersfield to try and ensure that the research pillar is completely embedded, from changing our third year module that was taught with all the other masters to having it as a bespoke module that's run by myself as an advanced practitioner to really enthuse our students. And we bring in a lot of international colleagues, so we offer collaborations, we offer international exchanges, we offer opportunities for students to get involved in research. We have an advancing practice special interest group specifically focused on research and enterprise, and really offering people opportunities. What's interested in our systematic review of systematic reviews is most of the studies do not involve advanced practitioners. So through the ICN Academy, we're trying to get more people involved, and we'll hopefully be developing early career researchers who are also working as advanced practitioners. And my wonderful colleague on the call from Dundee, Colette Henderson, we're about to embark on a survey across the United Kingdom on interest in terms of doctorates, PhDs, and how we develop advanced practice along that line.
Thanks for that. I'm just trying to see if we've got any more questions. Have I missed any? Don't think so. Vicky, you had your hand up, but it went down. Is there anything else you want to cover?
No, I was just going to comment on what James said, really, about recognising research in its broadest terms, really, in advanced practice. And one of the things that is really useful in the multi-professional framework, where it sets out the capabilities, you know, which helps students to understand advanced practice when they're first starting, is that it does recognise research as being very broad, and not just about, I mean, obviously it includes that, what we traditionally think of research, but it's much broader than that. And so it doesn't necessarily mean that they have to be removed from the patient-facing role that they've chosen to stay in, you know, by virtue of not becoming a full-time leader or a full-time researcher or a full-time educator. So I just thought that was a really useful point. Just wanted to emphasize that.
Okay, thanks for that. I mean, one of the comments that has been made is someone is talking in the questions has mentioned that they're running a CTIMP at the moment as an advanced nurse practitioner, running a trial at the moment, and they're the principal investigator. So there is obviously a lot of opportunities out there. There is also a comment about the whole debate about what is one's base registration versus is the AMP or ACP or advanced practitioner, whatever we're going to use going forward, is that the identity that we want to forge? But I think this is an area, this is a space, this is a landscape that is moving, evolving and changing. And I think these debates are going to go on and on and on. But can I take this opportunity to thank our four panelists, Professor Melanie Rogers from the University of Huddersfield, Louise Beasley, Associate Professor at the University of Birmingham, Vicky MacArthur, Associate Professor at South Oxford Brookes University, and James Pratt from, I always get this wrong, not University Hospitals Nottingham. No, it's
no, I don't know if I ever get it right, but that
right. But anyhow, it is from Nottingham University Hospitals. It's NUH, isn't it?
That's the one. Thank you.
Yeah, that's the one. For your insightful thoughts. Thank you so much for your time and your contribution. And this has been wonderful. Thank you. I'm going to now move to James from the Council of Deans, who wants to talk about how this group and these debates can be taken forward. So if I can introduce James to the audience, James Hollywood is the Head of Policy and External Affairs at the Council of Deans, and he's going to talk about next steps now.
Thanks so much, Annie. And look, thank you so much to the panel, but also to you, Annie, for the work that you've done over the course of this group. And the members of the group as well. I think
Yeah.
You know, this session for me really epitomizes why it would be such a shame if we then felt like we were now just drawing it to a close. And so it's just to kind of talk to all of the members of the advanced practice group and all of those involved in the council who are interested in this area, to say that it's not our intention to look at effectively a contract drawing to a close in terms of partnership with HE on this and then saying, conversation done, let's move on, because I think it's so clear that this conversation is only really getting started in terms of what we want to explore, the range of views, which we really welcome as well. You know, I think we're some way away from having a really tidy model of consensus on what we want from this. So as far as the council is concerned, what we would like to do is to continue this work stream going. We'd like to keep the group going. We'll happily work with you, Annie, and with members of the group to look at what the best model might be for that. But what I can confirm is that we will maintain this in its current form, and as it looks to evolve, as it might change, we can explore that along the way. But I suppose what I wanted to make sure was that I stepped in for the close of this, just to say that this isn't the close of a whole body of work. The work continues, and this has been a really fantastic first stage. And it was interesting just hearing members of the panel as well talking about the international situation and those comparisons. I was also there with the Australian delegation, and members of the council might have seen this news story about a shared statement that we put out with our colleagues in Australia, and we'll be working towards a memorandum of understanding as well. So with all of that going, actually, it feels like a really vital time at home and abroad to be looking at how we can do this here, what lessons we can learn, what lessons we can teach, as well as we kind of traverse this, but always walking step by step with our members on this. So thank you so much to everyone for your contribution over the stream of this work. I hope it's with excitement rather than dread when you think the work's not over, there's more to do. So it'd be really great to work with you in partnership on that, on how we go forward. So look, thanks once more. And look, genuinely, it's when you put these things together, it's really easy not to have there's often one person doling out the thanks and not getting it. And Annie, you will have thanked numerous panels and contributions, but a big thank you for the role that you've played in bringing this together and for keeping the momentum going on this. So thank you very much, Annie.
It's quite all right, James. What I'd like to do, just to finish off, to say that we've had a fantastic seminar series. This is the third and final, and I would say it's been really exciting, having lots of debates about lots of issues, but it shows the breadth and significance of the work that needs to go on and continue to go on. I think we're in an extraordinary space with the notions of regulation. And I think if any lesson from the participation I had in the recent consultation was, I think we always have to be very careful about what we wish for. And I find it very interesting that after people have met with the Australian group, that there are some reservations about regulation. One of the comments that was made, and I know from the work that Melanie will have been done internationally, regulation in lots of countries is much more about control rather than the opportunity to innovate. And that's something that we, being at possibly the forefront of academic careers in these ways, isn't it? Or practitioner careers in these ways, and the way we're optimizing talent in all sorts of ways and across the professions, is in the UK, regulation might be stifling in terms of that innovation. But we're in a great space. There's a lot of work to do, and we will continue to involve and probably lead internationally in the whole area of advanced practice. I think Julian wants a final word before we finish the seminar.
Thank you, Annie, and thank you, James, as well. Yes, indeed, we very much want to continue in the centre here, working in partnership and collaboration with colleagues at the Council to continue this key work in relation to the development and progression of the advanced practice agenda, as that style of working in partnership is key for progressing activities in this area of practice. I just also wanted to make note today that today is in fact the last working day of NHS England, as we move into merger with NHS England. So that will occur on the 1st of April, the legal merger of the two organisations. HE has established a clear agenda for the progression of advanced practice developments, including the key moment of the publication of the multi-professional framework and the creation of the Centre for Advancing Practice and its associated regional faculties. All of those have ensured a standardised approach for advanced practice education and training, and a shared understanding and common set of expectations of the work of advanced practitioners embedded across provider organisations. We'll be moving into a new directorate within NHS England called the Workforce Training and Education Directorate, and there will still very much be a key role for the centre there within that new directorate and its associated activities. So I just wanted to make note of that point after HE being in existence for 10 years, and I've been very pleased and privileged to have been involved in the work of the centre and its regional faculties, which will continue as we move into NHSE. So thanks all.
And I probably would like to finish on the note of saying thank you to HE on its last day, because these seminars and this working group has been very much a collaboration with Higher Education England. However, the Council of Deans represents the 4 countries of the UK, and advanced practice is not unique to England. So going forward, one of the big things is how we can all work collaboratively to learn from each other and really work at developing a unified approach, embracing diversity, complexity, and everything else that is in the field of advanced practice. And thank you everyone for your time. There will be a information that you're asked to fill in, so please do fill it in. And any comments anyone has, please do forward them to us at the Council of Deans. Thank you very much.
I'm just waiting a few seconds that people fill the feedback poll, and we'll be closing the webinar. But you're all free to go.
Thank you, folks. Wonderful, wonderful.
Thank you, Annie.
Thanks, Annie.
Lovely to meet you, James.
Thank you very much.
And Vicky.
Bye.
Good night, everyone. Bye-bye.
Bye.